everyone, welcome to this special video discussion. This is related to pediatric epilepsy syndrome. If you look at entrance exams, especially NEET super specialty exam, almost every exam has at least 1 to 2 questions on pediatric epilepsy syndromes. It is an extremely high yielding topic, and when we are doing these epilepsies, we tend to miss out on some of the important areas. So this is more like a MCQ oriented, exam oriented summary rather than me trying to take up individual topic and trying to explain inside out. The time I'll be spending on a topic will be related to its relative importance, the things which have been asked in the past exams and things which are likely to be asked in the future exams based upon their importance. So let us begin with the discussion. Now there are many ways of classifying the pediatric epilepsy syndromes. You can classify them according to age of onset, you can classify them on the basis of genetics, you can classify them based upon whether they are generalized or focal or a miscellaneous group. But from entrance point of view, there is one way in which pediatric epilepsy syndromes, it is always better to classify, and that is based upon prognosis, and then you can always sub-classify them as well. So broadly speaking, this is a atypical way. This is not a classic way of classifying. It is not a classification I'm talking about. What I'm talking about is exam point of view. In exam point of view, you will have questions in the past where they will ask you which among the following pediatric epilepsy syndrome does not have a good outcome. All of the following pediatric epilepsy syndromes have a good outcome except. So for questions like these, you broadly can divide into two groups, those which have a favorable or good outcome. And second category are those which have a unfavorable outcome or a poor outcome. When I say unfavorable outcome, basically what it means is there is either some degree of developmental delay in the child, or there is these are difficult to manage seizures which require multiple anti-epileptic drugs, and despite their use, the control may be suboptimal. All of them you will call as unfavorable outcome. Now, when you talk about those which are having a good outcome, you can further subcategorize into multiple subtypes. The first category are those which are having a neonatal onset. The typical example of a neonatal onset will be neonatal seizures called as benign neonatal convulsions. They are also called as benign idiopathic neonatal convulsions. They are distinguished from a separate group called as benign familial neonatal convulsions. Please understand that benign neonatal convulsion is a idiopathic disorder. This is an idiopathic disorder. There is no family history ever in these patients. On the other hand, these children are found to have a strong family history with autosomal dominant inheritance being a common picture. Both of them start in the neonatal period and they tend to improve as age progresses. Mostly they will not require any specific therapy. In a minority, you may need to give some anti-epileptics, and the response to anti-epileptics is excellent, and long-term neurological sequelae are usually not seen. Then we have children which have a later age onset. Onset later age. When I say later age onset, it basically includes a childhood onset or a post-infancy onset. In good outcome, this will include children with having so-called Rolandic epilepsy. Rolandic epilepsy has now been categorized as benign childhood epilepsy with centrotemporal spikes. That is the more common, more proper name of this entity. Then we have certain benign childhood epilepsies or benign epilepsies with occipital spikes, right? And then we have childhood absence seizures. And then you can have an adolescent onset. In adolescent onset, you will have children having two epilepsies which have a good outcome. One variety is juvenile absence seizure. For the purpose of discussion, we take them as together, like childhood and juvenile. They usually have a good outcome. They may require lifelong anti-epileptic medication, but mental retardation, developmental delay usually is not seen, and the control with a single monotherapy of anti-epileptic agents is good enough in majority of these patients. That is why we call them as a good outcome. It also includes an entity called as juvenile myoclonic epilepsy. So JME is also included in this category. So this is a separate condition, this is a separate condition. So please don't mix up the two. Juvenile absence seizure is different. Juvenile myoclonic epilepsy, also called as Jan syndrome, is different. But they both have an adult onset. Now coming to unfavorable outcome. In unfavorable outcome, you can remember that first of all, you will have those which have a onset in infancy, onset less than 1 year of age. That is onset in infancy. You will have syndrome called as Ohtahara syndrome. You will have Dravet syndrome, which will be strongly associated with febrile seizures. And there will be infantile spasms, or they may be a part of the West syndrome. And again, you will have childhood onset. Childhood onset will be usually beyond 1 year of age, usually 2 to 3 years of age, they will have an onset. This will include conditions like Lennox-Gastaut syndrome, which is very poorly controlled epilepsy. Suboptimal control is the rule rather than exception. And then you have Landau-Kleffner syndrome. The rare other epilepsies which are infrequently asked, I have deliberately not discussed them. But this classification which I have mentioned here, it covers most of the MCQ related points which have been asked to you in the exam. And I have also tried to mention about the corresponding age of onset in these patients. So this is a very, very important thing that you must remember from entrance point of view. Let us now discuss individual details. The first thing we'll be discussing is benign neonatal convulsions, also called as benign idiopathic neonatal seizures. The word idiopathic is important. And since they usually start on the 5th day of life, they are also called as 5th day fits. They were first described in 1970, and majority of children, it was found that usually 4th or 5th day of life they begin. So 5th day fit was the original term. But now we know that it does not portend anything other than the time of onset. So this thing is again, it is an outdated term. But if somebody says 5th day fit, they are basically referring to this entity, benign idiopathic neonatal convulsion. Now it is a self-limited. Self-limited means without therapy also it will improve dramatically. Non-familial seizure disorder. Non-familial is important because there is a familial entity also, which is a altogether different disease. The onset of this condition is neonates and usually happens around day 5 of life. So 5th day of life is the usual time. 5th day does not mean if it is starting on 4th day, you will not make the diagnosis. Mostly it presents median period of onset is around 5th day. The morphology, it is in the form of either apneic seizures. So there are only episodes of apnea associated with tachycardia in these patients, and sometimes these children may have focal motor seizures. So focal clonic seizures, focal tonic seizures have been described. What will EEG show? Now EEG findings are very specific and potential MCQ point can be asked. They have abnormalities not only during the seizure, that is ictal EEG, they also have a characteristic pattern in the interictal EEG. That interictal EEG pattern, that is between the seizure, it shows a pattern called as theta point 2 alternate. What is theta point 2 alternate? Theta waves are present. You know that theta waves are normally present in the EEG of a normal adult when he is sleepy or light sleep is there or drowsiness is there. That theta activity will be in the form of sharp waves with a frequency of 4 to 7 Hertz, and they will be intermixed with sharp spikes also in between. They will be non-reactive to stimuli. So whether you pinch the child or you give any type of photic or tactile stimulation, it will not change the background activity, and it will occur in sleep state as well as in the awake state. So that pattern is called as theta point 2 alternates. In fact, studies have shown that theta point 2 alternate can persist for as long as 12 days later, even after the seizures have totally stopped. And theta point 2 alternate is not specific for this disease. It can be seen in other unrelated conditions also. But theta point 2 alternate, which is self-limited, begins with the onset of seizures, starts from day 5 of life, and usually lasts for about ranging from a week to a month, is one of the finding which is suggestive of benign neonatal convulsions. Then when you look at the ictal EEG, you will find multifocal seizure activity in these patients. Now this is a photograph of a EEG which is showing the typical theta point 2 alternates which are present. There is a frequency of 4 to 7 Hertz along with of theta waves which are present, and these theta waves, as you can see here, there are theta waves, intermittent sharp waves, and occasional spikes can also be seen in these patients. So this is background theta point 2 alternate activity which is present. So, what is the cause of benign neonatal convulsions or idiopathic neonatal convulsion? The cause is unknown. However, AIMS protocol as well as Cloherty very clearly say that many patients are found to have low CSF zinc levels. But it is whether it is causative or simply present a coexisting association, we do not know. What is the treatment? The treatment wise, most of them do not require any therapy and they stop spontaneously in a few weeks, in a few days, 2 weeks. Usually, they do not persist beyond the neonatal period. So, within neonatal period, they will stop. In case there is a prolonged seizure episode, they respond well. If prolonged seizure happens, they respond well to IV benzodiazepines, or you can give IV phenobarbital as well. But both of them are only seldom needed. They are usually not needed. There is no long-term adverse neurological outcome, right? So this is the first thing that you need to know, benign neonatal convulsions. Quickly we move to the related entity which is familial in nature, benign familial neonatal convulsions, BFNC. Now benign familial neonatal convulsion is a familial seizure disorder, I have already told you. It shows autosomal dominant inheritance, potential MCQ point. Now what are the genes involved in this? There are 3 types of genes which have been involved. All the 3 genes are related to channel disorders in the brain. Mostly it is due to potassium channel disorder. A rare variant has been described due to sodium channel disorder as well. So the most common gene which is involved is KCNQ2 gene, which is present on long arm of chromosome 20, which is involved in 50% cases. The percentage thing is not mentioned in Nelson, but it is mentioned in Cloherty and other review articles. KCNQ2 gene basically codes for a voltage sensitive potassium channel present in the cortex and subcortex region, and there is one theory which says that maybe the newborn brain, either the polarization, hyperpolarization and depolarization signals are altered in these potassium channels, or simply it is a developmental abnormality which is self-limited related to the brain maturation. We do not know the reason, but again it is a benign condition and the child outgrows this condition in a few years. So most common is KCNQ2 gene. Remember that all the genes which are involved in BFNC, they all are present on long arm of chromosome. So second gene is KCNQ3 gene, which is present on long arm of chromosome 8, and then we have SCN2A gene which is present on long arm of chromosome 2. Both of these two, they code for voltage gated potassium channels in the brain, whereas this codes for sodium channel in the brain. Now, age of onset is about 2 to 4 days of life. So, maybe about 24 to 48 hours before 5th day fits, it usually begins. But there is a significant overlap. So, only by the day of life, when the seizures are starting, you cannot make the diagnosis, and they remit by 2 to 15 weeks of age. So, many of them can continue in the post-neonatal period, and they can continue in the first 2 to 3 months of the infancy period as well. Morphology wise, multiple types of seizures are seen. They can be in the form of ocular deviation, there can be tonic seizures, there can be multifocal clonic seizures, and there can be motor automatisms in the child. When you do EEG, interictal EEG is normal. This is very, very important clue. So if you have a child coming to you with neonatal seizures on day 5 of life and no organic cause is found, first look for any positive family history in the family, and then you do a EEG. In EEG, if it is a theta point to alternate pattern, you will think of idiopathic neonatal seizure. On the other hand, if the interictal EEG is normal, you will think of benign familial neonatal convulsions. Because if the father and mother had seizures in the newborn period, they themselves may not know it unless it has been told to them by their parents, right? So that kind of history may be sometimes lacking. So EEG is the investigation of choice, and interictal EEG will be normal. When you do ictal EEG, you will find the typical pattern of multifocal epileptiform discharges. Then management wise, usually again, many of these patients, no specific therapy is needed, especially if there are occasional seizures, occasional self-limited short duration seizures. Others, you may consider giving, according to Fanichel, oxcarbazepine has been found to be effective in these patients. But there is no role of levetiracetam in these patients. It is mentioned in Phenychil. Now, what about the long-term outcome? It is a benign condition. It is a good outcome in majority of these patients. There is no long-term neurodevelopmental abnormalities. However, there are two key points that you need to understand. According to Phenychil says that there is a 1/3 rule. About 1/3 of these patients may later on develop febrile seizures, and about 1/3 of these patients may develop future epilepsy. So long-term, when I say long-term neurodevelopmental outcome is not there, I simply say long-term cognitive neurodevelopment abnormality is not there. But febrile seizure and future epilepsies have been known to occur. Nelson gives a different range. Nelson says that about 16% patients of benign familial neonatal convulsions may develop future epilepsy. It only suggests that febrile seizures may be present at one place. So percentage wise, here it talks about 33%, here it talks about 16%. Other review articles give a range ranging between 15 to 35%. So it all comes down to what source you are using, what study you are quoting. But yes, as compared to benign idiopathic neonatal convulsion, these two risks, febrile seizure and future epilepsy, are significantly more. These are the things which are not there in idiopathic neonatal convulsion. End of the day, both are benign, right? But which is more benign, which is more, absolutely harmless, unless the child is, not being managed properly. That will be benign idiopathic neonatal convulsions, right? Moving further, the third entity, that is Rolandic epilepsy. Rolandic epilepsy is an old name. It is also called as benign Rolandic epilepsy, and it has now been called as benign childhood epilepsy. Benign childhood epilepsy with centrotemporal spikes. It is a benign condition. When you do EEG, you find spikes and sharp waves present in the centrotemporal region, also called as Rolandic spikes. Now, the cause of Rolandic epilepsy is unknown, but some cases have been found to be autosomal dominant in nature, and there is incomplete penetrance. Age of onset is between 3 to 10 years. It peaks at about 7 to 8 years and outgrows by 13 to 15 years. Usually we say that by the time pubertal changes are prominent, the disease outgrows itself, although no hormonal cause has been found. And morphology wise, they typically are nocturnal seizures, although daytime seizures have also been known to occur. The child typically wakes up at night with focal seizures being present, and there is preserved consciousness and comprehension. Now, it's a very, very important clue. These will be children between the age group of 3 to 10 years. They will wake up at night and cry and call their parents and say something is happening to me. They will say that they are having seizure, and these seizures will be in the form of focal seizures. Mostly they will involve the face. So there will be twisting of the face to one side, and they will speak like this as I am doing right now. They may be associated with the drooling of saliva from one side as well. Many of these children, in case they are having involvement of the speech area in the brain, they may have inability to speak. So aphasia or disarticulated speech have also been known to be manifestations. All through this, in almost 90% patients, the consciousness is preserved. In older times, they were also called as simple partial seizures with facial involvement. This term you will not find these days to be there. So they will have paresthesia. The word paresthesia is very important. Nelson does not talk about it, but Phenychil gives paresthesias a lot of importance. It says that paresthesias are a very frequent feature. Nelson says that buccal and throat tingling will be present in these patients. Tonic-clonic contractions of one side of the face will be there. There will be drooling, and inability to speak also may be seen in these patients. The word which is often described by patients is nighttime, sudden twisting of the face on one side, along with speech problems. Whenever you have a history in the language of the patient or the MCQ statement talking about this, immediately think of Rolandic epilepsy as the likely clinical possibility. Now, the usual seizure will last about 1 to 2 minutes, although smaller duration and longer duration have also been described. And rare patients may have some impairment of consciousness, and some patients may progress to secondary generalization, especially if these are nocturnal seizures occurring less than 5 years of age, right? Now, EEG will show centrotemporal spikes which will be wide-based, present more in the drowsiness and in the sleep. These centrotemporal spikes can easily be seen in the central and temporal region, particularly C3 region of EEG electrodes and T3, T4, T5 region of temporal electrodes. They will show you the areas. So as you can see in this pattern also, you will find that there are spikes which are present in the F7 T3 region here. You will find that F3 C3 region is showing some spikes here. The spikes can be positive, spikes can be negative. Spikes are usually sharp waves. Spike is something, if you try to think that I will sit on it, it will harm me. That sharp thing is called as a spike. Both positive and negative spikes, depending upon the orientation, have been described to happen in these patients. Again, I'm not going into the details of EEG here. All you need to remember is the key words, association of the typical EEG pattern of centrotemporal spikes along with the clinical history that will be given to you in the exam. It will never be a only EEG or a only clinical spectrum. There will always be a combination of the two if you look at the past papers. And Fenichel says that the frequency of spike discharge does not correlate with the subsequent course. And what is the management? Usually the outcome is good. Drug of choice in these patients are either oxcarbazepine or carbamazepine. Both of them are considered to be first-line agents. Carbamazepine are the drug of choice. Levetiracetam is considered to be the second-line drug. They usually have a good outcome, and they tend to, many of these patients, they outgrow the condition even without therapy. So without therapy also, these patients, they can outgrow the condition. Now, there is a thing called as atypical benign childhood epilepsy with temporal spikes. It has a younger age of onset. There are multiple seizure types, including drop attacks. There is an atypical EEG pattern, including secondary bilateral asynchrony. Developmental delay may be there, and response to oxcarbazepine or carbamazepine may or may not be present. But many of these children, again, will respond to levetiracetam. Now, moving further, there is a rare syndrome, also called as, it's a tongue twister, Peniato-Polos syndrome. Now, this is a syndrome where there is a benign epilepsy along with occipital spikes, not centrotemporal but occipital spikes. The age of onset is between 3 to 6 years, and some present as late as 14 years of age. But whenever it starts, basically within 2 years, it will disappear. Always remember that. Now, focal seizures will be more in sleep, and they are often associated with ictal vomiting. Ictal vomiting and autonomic symptoms are a very prominent feature of this syndrome. There is a loss of awareness as compared to Rolandic seizures. Autonomic features like pallor, sweating, sometimes syncope have been known to occur. Irritability, behavior issues, and tonic eye deviation can also be seen. Ictal EEG will show posterior slowing. Interictal EEG will show high amplitude 2 to 3 Hz, sharp and slow wave complexes in the posterior quadrant. So basically, posterior part, that is the occipital region, is mainly involved. And treatment wise, it responds well to usual AEDs, which includes phenytoin, valproate, etc. Levetiracetam again is a good option here, but not a first-line drug, at least according to the guidelines. But if you look at the practice point of view, it's a fairly effective drug. And most cases, they show remission in 1 to 2 years after onset. Please remember that even if they are starting at 10 years of age, by 12 years, they will be gone. So it's a self-limited, benign, relatively benign disorder, Peniato-Polos. The next group of seizures we'll be discussing are one of the most important from your entrance point of view, that is absence seizures. Question on absence seizure, a clinical case with EEG photo has already been asked in NEET super specialty exam in the recent past. So what exactly are absence seizures? Absence seizures, first of all, you need to know that they are also called as petit mal seizures or petit mal epilepsy. Grand mal is GTCS and petit mal is absence seizures. Now, according to Fenichel, absence seizures can occur in 4 distinct clinical entities. What are these 4 distinct clinical entities? This is something which is not mentioned in Nelson, but it is something that important that you should know. First is absence seizures are a part of childhood absence epilepsy. The typical absence seizure, The hallmark finding which starts between 3 to 8 years and continues for a few years, responds very well to ethosuximide or valproate, and then as adulthood comes, it tends to show remission. You can taper the dose. That kind of epilepsy, which is usually beginning and prominent in childhood, is called as childhood absence epilepsy. Conventionally, when I say absence seizure, I basically refer to childhood absence epilepsy unless proven otherwise. But being a specialist and aiming for super speciality, you should know that absence seizures can also occur in 3 distinct other entities other than childhood absence epilepsy. These entities include juvenile absence epilepsy. As we shall see, juvenile absence epilepsy is very similar to childhood absence epilepsy, just that it begins in the adolescent period. And secondly, this is usually a part of the spectrum of myoclonic epilepsy syndromes, right? The third absence entity in which absence seizures can be seen is Jan's syndrome, also called as juvenile myoclonic epilepsy. We'll be discussing this in details in some time. And fourth is epilepsy with grand mal on awakening, a rare form of epilepsy. The interesting thing is, Fenichel says that all the 4 usually tend to show autosomal dominant inheritance, but from entrance point of view and general speaking point of view, whenever we say the word absence seizure, we are referring to this variety, which is the most common association or most strongest association with absence seizures. The others are relatively rare compared to childhood absence epilepsy. And so, we'll be discussing in details about childhood absence epilepsy. Now, childhood absence epilepsy, first of all, age of onset, it is between 5 to 8 years in most cases, right? In fact, if the age of onset, the first seizure episode occurs after 10 years, we no longer call it as childhood absence epilepsy, we call it as a variant, that is juvenile absence epilepsy. Females are slightly more commonly affected than males if you look at the overall incidence. Many cases tend to show a autosomal dominant inheritance. However, Fenichel, Swyman and various other review articles, they say that it is not a very simple autosomal dominant he hai. There are other factors which are implicated and many genes which are still an area of active research which are involved, and so we do not know the exact cause. Some of the genes have been identified, which I will be talking about. Now, most of these patients, they are developmentally normal with normal cognition. You need to understand this point here. Now, childhood absence epilepsy, if you look at the development milestones, they are going to be normal. If you look at 20 years later, they are going to be normal adults. But once childhood absence epilepsy begins, you will find that children may have slightly decline in the scholastic performance. This decline in scholastic performance is not because the cognition of the child is getting affected. It is because the frequent absence seizures which are happening, they are interfering with the focus and attention span of the child. And so the child is basically confused, and so his scores start dipping. Once medications are started, once EEG has been controlled, and once you find that adequate remission has been obtained, these children, they tend to have a normal development outcome. So there are 2 aspects to this. Does it cause neuroregression or neurological problems related to cognition? The answer is no. Can it affect school performance? The answer is yes. Why is it affecting school performance? If the seizures are uncontrolled, then it affects school performance because the child is unable to concentrate. These are 2 separate things that you must understand, right? It is something like, I don't know whether you have related to that aspect or not. Many of you are younger, but some of you might be, you might have seen that phase. In the early 2000s, cable TV, cable satellite channels, they were there. But there were also, Doordarshan also used to be, still watched in your Indian homes, and often on Friday nights or on Sunday evenings you will have one of the recent movies coming up. So whenever, what they will do in those times is, there was a unsaid clause ki violence should not be shown to the kids. So what they would do is, additionally they will censor out the scenes. So whenever you are looking forward to ki in the end there will be an action scene coming up, you will have a scene where hero is going to confront the villain, and suddenly entire 10-15 minute sequence will be cut, and the last scene will be hero and heroine, they are hugging each other, and the end pops up, and you are like, what the hell? I knew they are going to be united, but I was waiting for the action sequence. So these children also have that kind of a problem. When they are trying to concentrate in the class, they are looking at a blackboard, they will have a vacant staring look for a few seconds, and suddenly the context will be lost. There will be no post-ictal confusion, but whatever thing the teacher was trying to say, that point will be lost. And there will be about 100 episodes in a day. So it will be like watching something, trying to concentrate, suddenly there is an episode, the context is lost. The teacher is trying to explain again and again but the child is unable to grasp because there are frequent episodes of seizures which are happening, which leads to loss of grades. These are, why am I stressing on it? Because you have questions in the past where they talk about decline in scholastic performance or fall in the grades when the child comes to medical attention. So students often ask, sir, you have said that there is normal cognition, why are the grades falling? They're falling because of the reason I just told you, right? Moving further, as I said, a multifactorial pathogenesis has been implicated, and the genetic locus in autosomal dominant cases has been found to be on GABRG2 gene present on 5q34. GABRG2 basically stands for gamma aminobutyric acid receptor gamma 2 chain, subunit gamma 2 chain, which is present on 5q34. This gene is mentioned in Fanichel and review articles, but it is not mentioned in Nelson. You can add it to your Nelson notes. Early onset cases. Now, there are certain patients with childhood absence epilepsy where seizures will occur before 5 or 4 years of age. They will show mutations in either SLC2A1 gene. SLC2A basically codes for a CSF glucose transporter, or it may show mutations in the GATM gene. These genes have been mentioned in Nelson as well at varied places, not in the discussion of childhood epilepsy, but in separate places they have been mentioned. And Nelson also says that if there is early age of onset less than 4 years, you should suspect glucose transporter defects, and these patients will show resistance to therapy. So early onset is usually associated with multiple drug requirement rather than monotherapy with anti-epileptic drugs. Now, what is the morphology of the seizure? This is something I would like to write and I like to explain. You already know it. Childhood absence epilepsy, first of all, it is in the form of multiple episodes. Multiple episodes, with each episode being having a duration. Each episode having a duration of about 5 to 10 seconds. And how many episodes can occur in a day? Up to 100 episodes can occur in a day. Certain children can have 10, 20, 30 also. Certain can have 150, 200 also. But about average 100 episodes will occur in these children. Each episode will last 5 to 10 seconds. What will happen in each episode? In each episode, there will be a brief, vacant, staring look lasting few seconds. There will be no aura. There will be no post-ictal confusion, and there will be no loss of tone or motor movements of limbs. In the typical cases, there are atypical cases also, but in a typical case, in the usual case, there will be no these features. So it will be like somebody has put a pause button on the child. So suppose I am having an absence seizure, while talking to you, suddenly without having any aura, I will go into a vacant staring look like this, and then I will continue speaking from wherever I had left. You ask me what happened, I would not know it. That brief vacant staring episode where I was not talking and only staring into nothingness, in Hindi we call it as shunya mein dekhna. Again, it's a complicated thing, you need not remember that, but again what it basically means is you are staring in one direction, no particular thing, and for that brief episode the patient does not know that he or she is having seizure. Immediately after the seizure, he or she continues doing whatever they were doing, so they will not have the awareness. That episode, that seizure is called as absence seizures. Now, although we say that it is a brief vacant staring look, textbooks do agree, including Nelson, Fanichel and Soyman, they say some of the patients may also have. So it does not mean that it is not absence seizure. Some of the patients, they do have either fluttering of the eyelids, briefly, very briefly, fluttering of the eyelids, or there may be a very small, brief, transient ocular deviation. It is not a rule, but can happen in some of these individuals. So transient ocular deviation may happen. Rarely, some of these patients may also show simple automatisms. They may show simple automatisms like lip smacking, or they may show picking at the clothes. But even these sequences, the entire duration will always be less than 10 seconds. And immediately afterwards, the patient will be normal. That is what you call as morphology of the seizure. Now, a very, very important thing, I'm writing with a different colored pen, highlighting, they are often precipitated by hyperventilation. They are often precipitated by hyperventilation for about 3 to 5 minutes. Certain books say 5 to 10 minutes. Usually what we say is hyperventilation, minimum 3 minutes should be done. Around 5 minutes of hyperventilation can precipitate it. Duration is not important, the precipitating factor is important. Hyperventilation. What is hyperventilation? Tachypnea is increased in the rate of breathing. Hyperventilation is increase in the rate and depth of breathing. So if a child is breathing like this is tachypnea. If he is breathing like this, that is hyperventilation. Hyperventilation has been shown to alter, why it precipitates, there is no specific reason for that, but studies have shown that hyperventilation produces certain changes in the cerebral blood flow sometimes, and it can affect the T-type calcium channels in thalamocortical areas of neurons and can precipitate absence seizures from these places. Again, it's a theory and it's not a well-accepted rule. So this is childhood absence epilepsy. Hyperventilation will precipitate the seizure. How can you hyperventilate? Again, there are multiple ways you can do it. You need a cooperative child for that. The best way is we take a piece of paper, or you have those candy toffee wrappers. You take that wrapper and ask the child to blow a whistle from that. So you take a wrapper and you blow. The child, when she starts doing, it is hyperventilation which is being done, right? And sometimes prolonged crying in a predisposed child can also precipitate, because children show hyperventilation during crying as well. So you may have a clinical scenario where the examiner is asking you that there was prolonged crying by the child and then a seizure was precipitated. Prolonged crying can produce hyperventilation. Please remember that, right? Now moving further, what will EEG show? EEG is the investigation of choice, and EEG will show the characteristic finding that is 3 Hertz. 3 Hertz means 3 times in 1 second, spike and slow wave discharge. Spike and slow wave discharge. What it basically means is that in 1 second, there will be 3 spikes and 3 slow waves, right? What is a spike? Spike is something which is pointed like this. Anything, I have told you just before that anything, if you try to think that I will sit on it and it will hurt me, that is a spike. Slow wave is something where you can sit and still not get hurt. So slow wave will be something like this, right? So this will be a spike, this will be a slow wave. If you count in 1 minute, you will find, suppose this is in 1 second, if you count, there will be 1 spike, 1 slow wave, 1 spike, 1 slow wave, 1 spike, 1 slow wave. So 3 spikes and 3 slow waves. That pattern will be called as classic pattern for absence seizures. You can have a look here. This is the photograph which is showing you that there is a generalized seizure episode. First of all, the electric activity is happening in all of these electrodes. So it is a generalized seizure. Secondly, if you try to see, you will find that the duration of epileptic form discharge, all these are 1 second interval. So it starts somewhere over here. So 1, 2, 3, 4, and then its seizure gets aborted. So less than 10 second duration. Now try to see in each second what is happening. Can you see? Let us have a look here. There is 1 slow wave, 1 spike, 1 slow wave, 1 spike, 1 slow wave, 1 spike. So spike and slow wave pattern, 3 spikes and 3 slow waves in 1 second are present. Here also you can see this. So 3 Hertz spike and slow wave pattern is being seen. That is what you call as classic pattern for childhood absence seizures. And also remember that certain reference books, they say that although discharge can be seen in virtually all electrodes, but it is very prominent. It is very prominent in the central and frontal electrodes or frontal regions of the EEG. It can be seen in temporal, it can be seen in occipital, but frontocentral or centrofrontal areas, the spike and slow wave discharges are very prominent. Now, what are the variants of childhood epilepsy? The first variant is atypical absence seizure. What we discussed was the typical absence seizure. It will be similar to absence seizures, except there will be associated myoclonic jerks. These jerks usually involve limbs, but they can also involve the perioral and sometimes even the peri-orbital muscles as well. But usually myoclonic jerks, they are they usually involve the limbs. Then there may be loss of tone, there may be head drop, loss of tone involving the neck alone or the entire body, and often they are precipitated not by hyperventilation, but they are precipitated by drowsiness. And when you do EEG, you will find that there is a 1 to 2 hertz spike and slow wave discharge. They show poor response to ethosuximide and usually show a better response to valproate. Then we have juvenile absence seizures. I talked about it. It is very similar to childhood absence seizures, except age of onset is beyond 10 years. Secondly, they occur as a part of juvenile myoclonic epilepsy syndrome. So they are more related to that disease than the childhood absence seizure themselves. They can be associated with GTCS too. Many of these juvenile absence seizures later on tend to develop generalized tonic-clonic seizures as well. EEG shows 4 to 6 hertz polyspike and slow wave discharge, which is classically seen in JME as well. So basically, it's a variant of JME. Somewhere, suppose you have on one side you have childhood absence epilepsy, other side you have juvenile myoclonic epilepsy. Somewhere in the middle, which is related to both but still distinct from each other, is juvenile absence seizure. And it is again usually refractory to ethosuximide and shows better response to valproate. And there are higher chances of persistent in the entire adult life. Childhood absence seizures tend to improve with age, whereas juvenile absence seizure usually require lifelong therapy. But again, they also do not cause any mental retardation or developmental delay in the child. Now, what is the treatment of childhood absence epilepsy? It's a slightly controversial area, but now we have a lot of reliable resources. So, first of all, we'll talk about the first line therapy. First line therapy, we have two drugs, ethosuximide and we have valproate. Now remember, if MCQ does not specify anything, they simply say what is the drug of choice. First line drugs are usually, you can think royal family. All of them are royals, but drug of choice will be the king. King can only be one, royal family can be many. So first line drugs, there can be 2, 3, 4, 5. But just like first line investigations can be many, but investigation of choice is one, drug of choice is one. So drug of choice will always be ethosuximide. It is usually the first drug to be started, and it is the most effective drug overall. Nelson also clearly says ethosuximide is the first drug to be started. Now, if the question says what is the drug of choice and they specify in atypical absence seizure, or they say drug of choice in absence seizure associated with GTCS also. Now, we find that GTCS will not be, responding to ethosuximide. So, in these patients, either of these two scenarios, the drug of choice now will become valproate, right? So, this is the first MCQ, this is the second MCQ that you need to know. What about the second line drugs? Second line drugs are used when first line drugs fail. Second line drugs are relatively less effective. So, first drug that is included in lamotrigine is that is included here is lamotrigine. Second is clonazepam. The problem with clonazepam is causes sedation and it is a benzodiazepine, so tachyphylaxis, that is decreased response with regular use, develops in clonazepam. Lamotrigine again effective but less effective overall, so it is a second line therapy usually used as a part of multiple drug therapy. And sometimes you can give a trial of zonisamide as well. But zonisamide is a relatively less effective drug as a monotherapy. Again, as an add-on drug you can add in some of these patients. Levetiracetam shows a suboptimal response. Topinamate, it is found to be not effective in absence seizures. Carbamazepine as well as oxcarbazepine are not effective, and sometimes they are not effective, and so this is the overall line of drugs that you need to remember. Now the problem is childhood absence epilepsy, even if the seizure frequency reduces, sometimes many of the episodes they are subclinical, and that is why EEG monitoring is needed to assess response to therapy on follow-up. Response to therapy on follow-up. So EEG monitoring will be needed to assess response to therapy. And do they require, all of them require lifelong therapy? The answer is no. A significant set of patients, once the seizures are well controlled, by the time they reach early adulthood or adolescent period, late adolescent period, many of them outgrew the disease. And usually it is found that children who show good response to first line drugs, they have a better chance of showing spontaneous remission. In these patients, you can consider tapering the drugs, provided EEG the patient has been seizure free for 2 years, and or even on EEG there has been no 3 Hz spike and slow wave pattern. In these patients, you can consider tapering, slowly tapering the drug and try to stop it. Now, potential MCQ extra thing. What are the factors associated with poor response to drug therapy in absence seizure? First of all, if the patient is having myoclonic jerk, the response to therapy may not be that great. Second is age of onset less than 4 years, resistance chances are more. Glucose transporter defects, there are more chances. G1 syndrome. What is G1 syndrome? If there is eye closure eyelid myoclonia associated with absence seizure, then again the chances of poor response to drug therapy are present. Now, Fenichel talks about a very important thing called as the classic triad of G1 syndrome. What is the classic triad? The first component is eyelid myoclonia with or without absence seizure. So there will be myoclonic movements involving the eyes, and it may sometimes be associated with a slight backward jerk of the head, and they may or may not be associated with absence seizures. The second component of the triad is eye closure induced generalized paroxysm. So generalized seizure activity may sometimes be induced. And thirdly, there will be photosensitivity on EEG. So on exposure to light or photic stimulation, specific spikes or burst pattern may sometimes be seen. So this is the classic triad of G1 syndrome. Now the next topic we are going to discuss is juvenile myoclonic epilepsy, also called as JME. Juvenile myoclonic epilepsy is also called as JAN syndrome. So this is first thing that you need to remember. It is the most common generalized epilepsy in adults, and overall it comprises about 5 to 10% of all epilepsies. Nelson gives a value of 5% and Fenichel gives a range of up to 10%. So it is actually 5 to 10%, which is the range. Now, gender preponderance is very controversial. If you follow textbooks like Fenichel, they say that males and females are equally affected. On the other hand, there are a lot of review articles and certain adult neurology textbooks which say that females tend to show a more preponderance compared to males. So there is no, basically what it comes down to is what kind of population are you studying and what kind of study are you quoting. Nelson takes the safe route. It does not take side and it does not talk about any male or female preponderance. The classic teaching has always been that females are slightly more affected than males, although Fenichel tends to disagree on this. The age of onset for juvenile myoclonic epilepsy is 12 to 18 years. Then most cases they tend to show autosomal dominant inheritance. And what are the genes implicated? This is a very, very important thing. Not in NEET SS, but in INI CET exam for entry into MDMS, some years back, there was question based upon the genes involved in GME. At that time, no INI CET was held. It was AIMS entrance exam which was there. Now we call it as INI CET for PG entrance, and we know that certain topics, certain things which have been asked there can sometimes, indirectly be asked in the super specialty exams also. So they had asked about the gene involved in GME. We need to know what are the genes involved, and obviously we will be reading slightly more in details compared to what is required at undergraduate level. So genes implicated, there are 3 genes that you need to remember. The first gene is CACNB4 gene. Second gene is called as GABRA1 gene, and third gene is called as EFHC1, which is the alternative name for this is myoclonin 1 gene. All the 3 genes have been implicated. In the Western population, CACNB4 has been found to be more commonly affected. On the other hand, in certain populations, especially related to Asian studies, you will find that GABRA1 has been found to be very frequently associated. But which one is the most common? Again, it varies across the ethnicities, and nobody is going to ask you which is the single most common. It is that these 3 comprise almost 90 to 95% of the genetic forms of juvenile myoclonic epilepsy. Now, what is the morphology of seizures which happen in GME? The hallmark of juvenile myoclonic epilepsy is myoclonus. It occurs in the form of jerks, so it is also called as myoclonic jerks, which are seen in 100% of these cases. Without the presence of myoclonus, there cannot be juvenile myoclonic epilepsy. They always develop at some point in the life. Now, the pattern of these myoclonic jerks is very, very interesting. They tend to occur in the form of flexor jerks which are brief, repetitive and bilateral, even though they may not always be symmetrical, and it occurs in the limbs. They often occur in the morning when the child gets up from sleep, and it will occur in an awake state. So there will be intact consciousness in these patients. Initially when they start, they usually involve the limbs, and so there will be frequent falling or dropping of objects from the hands, which is an early clue. There was an MCQ which was framed some years back. The question went something like this. There is an adolescent female of 12 years who has noticed recent frequent falling of objects from the hands due to jerks. These jerks occur in awake state and more prominent in the morning hours. Her EEG showed an abnormal pattern. There is also a family history of her elder sister sibling who developed similar features and is currently on medication. What is the likely diagnosis? So everything is fitting into juvenile myoclonic epilepsy. So because it commonly involves hands, so they may hold something in the morning to comb their hand, and suddenly there will be a jerk and there will be falling of object from the hand. Many times they can involve the lower limbs also, and so it can result in falling of the person as well. Then these jerks, they are precipitated by photic stimulation. So when the person gets up in the morning and rays of light fall on their face, the seizures can be precipitated. It can also be precipitated by sleep deprivation and alcohol use, particularly in older individuals. Now, when you do EEG in these patients, you will find a specific pattern, 4 to 5 or 4 to 6 Hertz polyspike and slow wave discharges, which are precipitated by photic stimulation. So, photic stimulation is essential on EEG when you do EEG testing in these patients. Other than myoclonic jerks, generalized tonic-clonic seizures tend to develop in 50 to 90% cases, but they tend to occur quite late, usually around 18 to 20 years or later they will appear. And then juvenile absence seizures tend to occur in 25 to 30% cases additionally. In fact, some certain patients, juvenile absence seizure may sometimes precede the development of myoclonic jerks. However, myoclonic jerks are considered to be the hallmark and they are always present. Now, what is the treatment of JME? Treatment is simple. Drug of choice in these patients is always valproate. And valproate needs to be given lifelong. JME does not cause any mental retardation or fall in the cognitive abilities. So from that aspect, they are fine. But once a patient has been diagnosed with JME, it is very unlikely the patient will undergo spontaneous remission, and usually lifelong therapy, lifelong antiepileptics are needed. If you compare with childhood absence seizures, I had told you that many of them do show spontaneous remission also, but here lifelong therapy will be needed. Alternative therapies effective in JME are the two L's. You can include levetiracetam or you can use lamotrigine. So this is the management of JME that you need to remember. Moving further, we have severe epilepsy syndrome. So we'll be going into the zone of severe epilepsies, and obviously we'll be starting with young age syndromes. First of all, we'll be starting with Ohtahara syndrome. Ohtahara syndrome is also called as EIEE, that is early infantile epileptic encephalopathy. Please note that there is no myoclonus word mentioned here. It is not a myoclonic epilepsy. If there is myoclonus present, it is not Ohtahara syndrome. Remember the key word Ohtahara syndrome, there is no myoclonus. This clue will help you massively in your MCQ entrance exam. If the question talks about encephalopathy, severe seizure in a child less than 1 year of age, and they mention the word myoclonic jerks or myoclonic seizures, Ohtahara syndrome will not be the answer, right? Ohtahara syndrome always has severe tonic seizures but not myoclonus. So, it is a severe early onset epileptic disorder with the age of onset within the first 2 months of life. It starts either in the neonatal period or in the 1 month after the neonatal period. So, always it will begin with in the first 2 months of life. Now, there will be tonic seizures which are refractory and progressive encephalopathy with delayed development that are the hallmarks of the disease. So, it is a very severe kind of epilepsy. What are the genes associated with Ohtahara syndrome? Syntaxin binding protein 1, STXBP1 gene is implicated in majority of these patients, and it is present on 9q34.1. The Ohtahara syndrome associated with this is also called as EIEE type 4. It is an old nomenclature, but somebody asks you which type of early infantile epileptic encephalopathy is associated with this gene or protein abnormality. The answer will be EIEE type 4. Other genes which have been associated, they include ARX gene on XP22.13, and there is also a STK9 or CDKL5 gene present on again XP22 locus. Now many cases are also associated with malformations of the brain. Now what is the diagnosis and therapy? How you are going to make the diagnosis? When you do EEG, you will find a burst suppression pattern. Burst suppression pattern has been described in multiple conditions. It has also been described in patients with hypoxic ischemic encephalopathy stage 3, and Ohtahara syndrome again can have similar pattern. In case there is a burst suppression pattern, you will go in for genetic testing, and genetic testing can always help you reach the correct diagnosis. How does burst suppression pattern look like? Something like this. You will find that there is a burst in all the waves followed by suppression of electrical activity. Then there will be a high voltage, high frequency burst. Then there will be suppression, then a burst, then a suppression. That kind of pattern will be seen. Now treatment in these patients is difficult, and the seizures are usually refractory. Many of these patients, they respond to the same drugs for which we use West syndrome. So many patients respond to ACTH, they respond to vigabatrin. Certain patients also respond to the newer anti-epileptics. Topiramate has been tried, but the response to many of these drugs is suboptimal. And it is found that most of the Ohtahara syndrome patients, they usually develop features of West syndrome in late infancy. So beyond 6 to 7 months of age, many of these children which are having Ohtahara syndrome goes away and it turns into West syndrome, where there will be infantile spasms happening, there will be severe developmental delay, and the patient will show hypsarrhythmia on EEG. So Ohtahara syndrome, natural history wise, it will develop into West syndrome. Please remember that. Now moving further, what is the differential diagnosis of Ohtahara syndrome? A syndrome, a pediatric epilepsy which starts in the same age, but it is not Ohtahara syndrome. The name is early myoclonic infantile encephalopathy, EMIE, also called as early myoclonic epileptic encephalopathy. If you see carefully, these terms can be confusing. Early means it is starting within first 2 months, but there is myoclonic activity present in these patients. Encephalopathy is there, just like Ohtahara. There was no myoclonus, there were severe refractory tonic seizures. Here there will be myoclonus which will be present. So they will have a similar age of onset, less than 2 months, similar encephalopathy and EEG findings like burst suppression pattern. They will show severe myoclonic seizures instead of tonic seizures which are seen in Ohtahara syndrome. They show poor response to therapy. Drugs used are almost similar to what we use for Ohtahara syndrome. So please remember, age of onset less than 2 months, severe encephalopathy. Tonic seizures, think of Ohtahara. Myoclonic seizures, think of early myoclonic infantile encephalopathy. Right? Moving further, the next syndrome we'll be discussing is Dravet syndrome. Dravet syndrome again has onset in infancy, and Dravet syndrome is considered to be a fever-associated severe epilepsy. So Dravet syndrome, what are the key things that you should know? First thing, it is also called as severe myoclonic epilepsy of infancy. In short, it is also written as SMEI. So SMEI, sometimes they write it. It is the other name for Dravet syndrome. It is considered to be a febrile seizure. It is considered to be a febrile seizure associated epilepsy, and onset is always in infancy. It mostly occurs due to de novo fresh mutations, but sometimes autosomal dominant inheritance can also be seen. And what are the genes implicated in Dravet syndrome? Again, a very important potential MCQ. The most common gene involved is SCN1A gene, which is implicated in 80% cases. There is loss of function mutations, and the gene local is 2q24. Please remember that SCN1A gene is also involved in generalized epilepsy with febrile seizure plus, the so-called GEFS plus syndrome. I'll be talking about it in some time. The gene is same. When there is complete loss of function, it produces Dravet syndrome, the severe manifestation. If there is a partial function which is retained, it tends to produce GEFS plus syndrome, right? So severe mutations are implicated in SCN1A. And this gene, there are commercially methods available for the identification of this gene. So Dravet syndrome can be diagnosed in a good subset of patients, because almost 80% you will find this gene mutation. Other than that, the genes which have been implicated include SCN2A, SCN1B, and GABRG2 gene, which are the other genes associated. No gene has been identified according to Nelson in 10 to 20% cases. Now, what is the clinical spectrum of Dravet syndrome? First of all, it begins as complex febrile seizure. Early onset hoga, complex febrile seizure honge. It will be typically in the form of focal febrile seizure. There will be unilateral clonic seizures occurring in clusters every 1 to 2 minutes, precipitated by fever, and are usually more prolonged. You know that even if there are complex febrile seizures, in case they are non-syndromic, the usual ones, you will find that they are brief in nature and they will, not be so prolonged, they will not be so recurrent. But here they will be occurring in clusters. Once fever is the trigger and it starts, it will just not stop. Those kind of seizures will be suggestive of Dravet syndrome. And sometimes you will find that generalized febrile seizures can also develop, and febrile status epilepticus has also been known to occur. As age increases, you will find that seizures start to develop even with low grades of fever. Initially they are with high grade, and later on, maybe around end of infancy or beginning of second year, you will find around first birthday, you will find that seizures are now happening without fever as well. So afebrile seizures will also start happening. So what will happen in the second year of life? After the child has celebrated his birthday, you will have more types of abnormalities coming. You will find that there are now myoclonic seizures, atypical absence seizure, focal seizures, and developmental delay becomes apparent. Please remember, Dravet syndrome, although it has been described, but delayed milestones are a feature beyond first birthday, and they coincide with the development of myoclonus. Very, very important point. Development of myoclonus and occurrence of developmental delay both occur concurrently, and they both begin immediately after 1 year of age is over. This is a very characteristic history point that is suggestive of Dravet syndrome, especially in an Indian setting where patients tend to present quite late. And now we know that Dravet syndrome actually accounts for most cases which were earlier labeled as vaccine encephalopathy in the past. In fact, Nelson also says that ho sakta hai, there is no such thing as vaccine encephalopathy. If you look at 20-30 years back, there were certain children who would be given injections, who would be given vaccination, and they will develop, encephalopathy, regression of milestones, and frequent seizures as well. So people would assume that it is due to DPT, certain people would assume that it is due to MMR, and so on. Not specifically MMR, the measles component which is causing, but later on it was found that almost a big chunk of these patients were having Dravet syndrome. When their sequencing was performed, retrospectively when they were looked, there was a family history of mutations involving SCN1A. So maybe the child was given DPT whole cell vaccine caused fever, and that fever precipitated seizure in the child, leading to development of Dravet syndrome with encephalopathy. So vaccine administration was only incidental. So this is an important point mentioned in Nelson and also elaborated in many review articles, so you must remember that. Now, Fenichel says some interesting points. First of all, it says that seizures in Dravet syndrome are worsened by sodium channel blocking AEDs like carbamazepine, oxcarbazepine, phenytoin, and lamotrigine. So this can be a potential MCQ. They can ask you which drugs worsen. They can ask you which drug should be avoided. They can ask you a history like thing. They can make a patient was given, the child had this. He was started on this drug and there was worsening. Tell the likely diagnosis, it will be Dravet syndrome. Generalized myoclonic seizures, I have already told you, they begin beyond 1 year of age. Once myoclonic seizures begin, patient develops developmental delay, and later on, around end of second year, you will find ataxia and hyperreflexia also to develop in some of these patients. And diagnosis is made by phenotype along with genetic testing. Initial baseline EEG you can do, but repeated EEG testing is not indicated. EEG will simply show epileptiform activity. Sometimes background burst suppression may sometimes be seen, but no specific EEG abnormality has been found to be pathognomic for Dravet syndrome. So that is why phenotype, baseline EEG, and genetic testing are the ones that we usually perform. Now, what is the therapy for Dravet syndrome? Therapy-wise, effective first-line medications include valproate and clobazam. Valproate is usually the first drug to be started. especially in children above 2 years of age. Less than 2 years, we can start the patient on clobazam. Stiripentol is very effective, but stiripentol is costly. It is not available, and stiripentol produces a lot of drug interactions. So it increases the level of certain drugs. It gets affected by certain other drugs. So those levels need to be monitored. Other drugs which have been found to be useful, they include levetiracetam, topiramate, zonisamide, and rufinamide. They have been found to be effective. Cannabinoids in age above 2 years is FDA approved for these patients. Potential MCQ. You start at 5 mg per kg per day in 2 divided doses, that is 2.5 mg per kg morning, 2.5 mg per kg evening. It is an oral medication, and you can increase gradually to 10 mg per kg per day. If there is partial response, maximally you can go up to 20 to 25 mg per kg per day. So 10 to 20 is the maintenance dose that is given per day, per kg per day. And then ketogenic diet may be useful in refractory cases. You should avoid sodium channel blocking agents, the ones which I mentioned, as well as barbiturates. Giving barbiturates, especially in febrile status epilepticus, has been found to have a adverse neurological outcome in these patients. And genetic counseling is recommended because even though the de novo mutations are there, if these mutations involve the germ cell line, they can be transmitted in the family, and some of these patients, they do have autosomal dominant inheritance as well. So genetic counseling is recommended in all identified patients of Dravet syndrome. Moving further, what is the DD of Dravet syndrome? I've already talked about it. GEFS plus, generalized epilepsy with febrile seizure plus. It is due to similar gene mutation as Dravet syndrome, but milder gene mutations. Autosomal dominant, and they have a variable phenotype. They have a positive family history, and they typically present as febrile seizures, later which progress to afebrile seizures. The degree of developmental delay is usually mild compared to these patients, and they respond to similar drugs as for Dravet syndrome. Some may show remission in later life as well. The next topic is a star topic from entrance point of view. West syndrome, also synonymously used with infantile spasm, is one of the very frequently asked topic in all entrance exams. So we'll be discussing a bit of details here, and there have been recent guidelines, terminologies given by ACUN in 2021. So those also I shall be briefly touching upon. So West syndrome, first of all, what is the age of onset? It is between 2 to 12 months. It usually does not manifest in the neonatal period, but anytime between 2 to 12 months it can manifest. The peak onset occurs between 4 to 7 months according to Fenichel as well as two standard review articles. Now West syndrome is also called as, the hallmark of this is infantile spasms. The word infantile is used because West syndrome always begins during infancy. So the key thing to remember is the onset is always in infancy. If the onset occurs beyond 1 to 2 years of age, you will not consider West syndrome, it will be something else, but certainly not West syndrome. The syndrome can continue up to 2 to 3 years of age, sometimes even later in a minority of cases, but the onset will be in infancy. Now, what is the classic triad of West syndrome? The classic triad includes basically three things. First is infantile spasm. The classic triad includes three things. First is infantile spasm. The second part of this triad will be developmental abnormalities. Nelson uses the term developmental regression. Certain other books call it as developmental delay. Usually what we find is delay and regression tend to coexist. So developmental regression and delay will be the second part, and third will be the EEG abnormalities. EEG showing a specific pattern called as hypsarrhythmia. A chaotic EEG, which I will show you in some time. So these are the three parts, the classic triad of West syndrome. Now, what are the etiology and types? Now, broadly speaking, West syndrome is divided into two parts. First variety is the so-called cryptogenic West syndrome. Cryptogenic is also called as idiopathic, and as the name suggests, no cause can be found. No cause can be found. The second variety of West syndrome is called as symptomatic West syndrome. Symptomatic West syndrome was previously also called as secondary West syndrome. These are the patients who are having an underlying abnormality in the form of some perinatal asphyxia. They may be having some structural brain disorder. Many of them are having an underlying neurocutaneous syndrome, for example, tuberous sclerosis. Tuberous sclerosis. The important thing to remember is that cryptogenic or idiopathic form can sometimes be, does not come to attention late. And usually West syndrome begins as, it occurs in a patient who does not have any previous underlying neurological problem. The patients who are having symptomatic one, they will be having sequel. The West syndrome usually develops as a sequelae. On the other hand, cryptogenic, no prior abnormality will be there. And the critical time is about 3 to 4 months, during which you should have adequate seizure control, adequate spasm control in patients with cryptogenic West syndrome. It is found that patients who have prolonged episodes of poorly controlled infantile spasms, or those who come to attention late, they have a poor prognosis. On the other hand, cryptogenic cases which are managed, diagnosed and treated very early, aggressively, they are found to have a relatively better cognitive ability in later life. In case of symptomatic, how much will be the effect on cognition will depend not only upon seizure control, it will also depend upon the underlying brain problem which has produced West syndrome. In general, you need to remember that more control, early control of the seizure is, the better is going to be the cognitive ability of the patient, right? Now moving towards the hallmark finding of West syndrome, what is the typical clinical picture or clinical spectrum that we find in West syndrome patients? As I said, the hallmark of these patients is always infantile spasms. Infantile spasms are also called as infantile epileptic spasms. What exactly these are? These are spasm-like jerks which commonly involve the limbs, trunk, as well as head and neck, but are very frequently seen in the limbs. They are usually symmetrical in nature, but can be asymmetric as well. They usually, when they occur in limbs, upper limbs are more frequently involved than lower limbs. However, all 4 limbs of the body can be involved. These spasms are usually precipitated by either drowsiness or awakening from sleep. These infantile spasms, they tend to occur in clusters, and each cluster will have about 10 to 100 spasms occurring in the same patient. How many actual number will be there? It will vary from child to child. And it is found that infantile spasms frequency and control directly correlates with decline in the developmental milestones. Also, you need to understand that infantile spasms are most frequently of the flexor type compared to extensor type. However, both flexor and extensor in certain, a minority of patients have been described in the same individual. Although they will not occur together, they will occur at different times. In general, flexor spasms are more common. So what exactly is infantile spasm? Suppose I am a child who's having West syndrome and I have a flexor type of spasm. So what will happen is, on awakening from sleep, I will go into a spell in which there will be sustained contraction of the jerky contraction of the upper limbs towards the trunk, and simultaneously there will be flexion of the neck also. The neck will flex and my limbs will come in the center like this. So I will start doing like this. This will be one sustained contraction. Then I will relax, another spell will happen, then third will happen, and it will keep on happening about 10, 20, 30 or up to 100 times it will happen. Then I will become normal. This is called as one cluster. After some time, another cluster may soon start when I start to go back to sleep or drowsiness happens. So these are the typical flexor spasms. Variations of this clinically can exist. There may be patients in whom the neck may not be involved and the child is simply doing like this. So many times these patients may be confused with startle, exaggerated startle response. But exaggerated startle in this age group associated with developmental delay is less likely to happen. Many times some of these children will have extensor variety, and extensor variety again can be missed. So extensor variety will be very similar to how you do the Morrow's reflex. So how you do Morrow's reflex? When you do Morrow's reflex, you suddenly hyperextend the neck and the child suddenly outstretches his arms and his neck goes into extension. This is what you do in Morrow's reflex, right? When you elicit it. So these children also, whenever there will be extensor spasm, they will start doing like this. There will be extension of the neck and there will be extension of the upper as well as lower limbs. So similarly, they will do like this. So they will do like this, or they will have features like this. So these are the different types of spasms which have been known to occur. Spasms are better seen than described. But don't worry, video MCQs are still not coming in the exams, and I hope everybody has an idea who has passed their MD. You would have seen, you would have read, you would have managed patient of infantile spasm to know what the thing is. Since it's an MCQ oriented thing, so I'm not going into unnecessary technical and practical details because it will only prolong the video, but I'm trying to cover as many points as possible to make it clear. So these are the key features about infantile spasms that you need to know. Now before we go towards the investigation and EEG part, there are a few terminologies which have been explained and recalibrated in the new guidelines. So what are the AOCN 2021 guidelines? What are the terminologies they have come up with? So these terminologies can be asked as standalone MCQs. It's the latest thing. It's not there in your Nelsons. And unless you are reading review articles, this is something you would not have read so far. So let's go through it. First of all, what are clinical spasms? What we call as infantile spasms. So they are brief synchronous movements involving head, trunk and limbs, or sometimes of the head, trunk or limb alone, any of these alone, occurring for about 1 second. So ranging between 0.5 to 2 seconds, just like I showed. These may be flexor or extensor or mixed. As I said, both can coexist in the same individual, and they can be symmetric as well as asymmetric, although symmetric is more common. Spasms typically occur in clusters and are seen before falling asleep, in drowsiness, or when waking up from the sleep, which is more common. And then subtle spasms can be there. What are subtle spasms? Episodes of activities like head nodding, facial grimacing, eye movements, yawning, gasping. If you do EEG, you will find hypsarrhythmia. Unfortunately, subtle spasms are not very easy to identify. And infantile spasms, single spasm variant, are those infantile spasms which occur singly and not in clusters. So instead of multiple episodes, it may simply be in the form of one jerk and then the child is fine. So they are often missed. They are often missed and they are sometimes confused for a startle response also. Then there can be epileptic spasms. Whenever there will be a clinical infantile spasm and EEG will be showing an epileptiform discharge, we will call it as epileptic spasm. Then epileptic spasms without hypsarrhythmia. If there will be clinical spasm, there will be EEG recording, but other than hypsarrhythmia, we will call it as epileptic spasms without hypsarrhythmia. And then what is West syndrome? This is very, very important. Very, very important. So children who have infantile epileptic spasms in clusters, along with EEG showing hypsarrhythmia or its variants, you will say the patient is having West syndrome. Please understand, there are two aspects I want to clarify here. If somebody asks you what is the triad of West syndrome, the three components are infantile spasm, hypsarrhythmia, and developmental abnormalities, right? If MCQ asks you what is the definition of West syndrome according to the updated AOCN guidelines, similar guidelines have been proposed in the Delphi protocol, in the Delphi consensus statement as well. They say that developmental abnormalities are not essential to make the diagnosis of West syndrome. They can be there, they are a useful clue, but by themselves, they are not sufficient, they are not needed in case the patient is having a clinical infantile spasm, number one, along with hypsarrhythmia. It can be a hypsarrhythmia classic one or some variation of hypsarrhythmia. If both of them are present in the same child, that is sufficient to make the diagnosis of West syndrome. Please remember this, very, very important for your exams, right? Major change. Now moving further, why infantile spasms happen? We frankly do not know. There are three theories. So these three processes have been implicated singly or in combination, and they have also been mentioned in Nelson. So first is increased CRH, corticotropin releasing hormone. Studies say that children with symptomatic West syndrome, those who have structural abnormality or any perinatal asphyxia or hypoglycemic injury or sepsis or trauma, there will be abnormally increased production of CRH. This CRH will lead to the development of ACTH and will be involved in stress response in the body. For some unknown reason, probably due to immature brain, the CRH will not undergo feedback inhibition. This CRH will be abnormally elevated. It will be abnormally produced in certain areas of the brain where it is not supposed to be, and this will be epileptogenic. First possibility. That is why ACTH by feedback inhibition, some high dose ACTH by feedback inhibition can produce control of infantile spasm. Second is sodium channel blockade has been shown to produce or worsen infantile spasm. So anti-epileptic drugs which produce sodium channel blockade, they are not effective and in fact contraindicated, relatively contraindicated in West syndrome. And third are the NMDA receptor stimulation. NMDA receptors, sometimes in response to brain injury, sometimes as a part of syndrome, they are upregulated in certain brain areas, and these also have a pro-excitatory effect leading to infantile spasms. Please remember also that infantile spasms, West syndrome tends to go away as the child progresses. After 2, 3, 4 years of age, usually West syndrome disappears. What the child is left with is either sequelae of that, which is developmental delay, or some other refractory epilepsy like Lennox-Gastaut syndrome, which we will talk about in some time. So, what are the EEG findings in West syndrome? The classic EEG finding is hips arrhythmia. What is hips arrhythmia? Hips arrhythmia has been described as, you can see it here also, it is a chaotic, high voltage, variable, high amplitude, electrical activity, interspersed with occasional sharp spikes. And usually suppression activity is minimal in these patients. So this is the typical hips arrhythmia. Can you see? All waves merging into each other, and it is a generalized wave activity. There is no EEG which is similar to hips arrhythmia. They say you have seen this EEG, you keep the photograph in your mind, you will never go wrong in the exam. Now, according to guidelines, there are diagnostic categories of West syndrome based upon what are the clinical features and what are you finding on EEG. So first is confirmed West syndrome. If the interictal EEG between the seizures, it is showing hips arrhythmia or its variants, plus there is electroclinical documentation, that is during ictus there is a electrodecremental response, that is a specific seizure activity begins rather than chaotic high voltage EEG, or there is a clinical home video where there is a infantile spasms occurring cluster that is there, you will call it as confirmed West syndrome. So this category, the new guidelines, they give a importance to home recording of videos in these patients as well. So make it a point anytime the parents say that our child is showing abnormal activity or abnormal behavior, ask them to take a video. Everybody has good quality mobile phones. Take videos many times based upon what parents have recorded, you can make the diagnosis. It makes a huge difference. Second is probable West syndrome, where there is a high diagnostic certainty. When clinical history suggestive of spasm, there is no video recording, but EEG shows multifocal discharges, but not hips arrhythmia or its variants. So exact hips arrhythmia is not there, EEG abnormality is there, and clinical history is suggestive of infantile spasm, age is between 2 to 12 years onset, that is probable West syndrome. And third will be possible West syndrome, low diagnostic certainty, when history of spasm is doubtful and EEG shows multifocal discharges and not hips arrhythmia or its variant. This will be called as possible West syndrome, right? Then what is the management according to these guidelines? Management is very detailed, and I'll be just summarizing it once. Please remember also that MRI brain should be done in most of the patients of West syndrome to identify underlying structural cause. MRI is the investigation of choice for neuroimaging compared to CT scan, but MRI is not essential for making the diagnosis. MRI is only to identify whether there is an underlying structural abnormality or not. Now, how you're going to manage? You know that ACTH is the drug of choice. So, the therapy of choice is hormonal therapy according to the latest guidelines. What I have discussed here is according to AOCN guidelines, interspersed with some points taken from Nelson. So you get everything at one place. So ACTH is the preferred agent, adrenocorticotropic hormone, usually given parenterally. High dose regime of ACTH is used. ACTH is used in a dose. There are two types of regimes. Nelson only talks about body surface area regime. The AOCN guidelines talk about per kg body weight also. So ACTH according to Nelson as well as AOCN is 150 unit per meter square body surface area, or according to AOCN 6 unit per kg intramuscular once daily for 2 weeks, right? Usually we see that clinical response in responsive patients, usually clinical response develops in about 7 days, but we give it for 2 weeks to see whether some patients are late responders or not. If ACTH is not available, you can give high dose prednisolone as well. The usual prednisolone dose that we follow in nephrotic syndrome is 2 mg per kg per day. This is the one entity where high dose prednisolone 4 mg per kg per day in 1 or 2 divided doses is given again for 2 weeks. And Nelson says that oral steroids are inferior to ACTH in cryptogenic West syndrome. Very, very important. And that is why ACTH, where possible, it will be the therapy of choice, except one scenario, that is tuberous sclerosis. In tuberous sclerosis, vigabatrin will be the drug of choice. The problem with ACTH and steroids are manifold. You know that they are going to cause infections, they are going to cause steroid related side effects, and in fact ACTH after giving for 2 weeks, prednisolone giving for 2 weeks, after control has been achieved, you need to taper them, and even during tapering you may sometimes have seizures happening again. So you need to do follow-up EEGs even if there are no clinical seizures at 1 week, 2 week and 4 weeks of starting the therapy. What about vigabatrin? It is given if ACTH or steroids fail or are contraindicated. It is preferred over ACTH in West syndrome associated with tuberous sclerosis. So in general, they ask drug of choice, ACTH or prednisolone. If they ask specifically in tuberous sclerosis, the answer will be Viga. So if MCQ asks what is the drug of choice in West syndrome in general, answer will be ACTH. Not an option, prednisolone. If they ask drug of choice in West syndrome associated with tuberous sclerosis, the answer will be vigabatrin. The problem with vigabatrin is risk of retinal toxicity. Nelson says 30% patients of vigabatrin therapy develop retinal toxicity, especially if given for more than, equal to or more than 6 months. And so in these patients, ophthalmological evaluation is regularly needed. Now, if both hormone therapy and vigabatrin fail, you need to give a trial of benzodiazepine, valproate, topiramate or zonisamide. Either of these can be given. What is the role of dietary therapy? So, if you have given either hormonal therapy or vigabatrin plus one additional AED out of these 4 and they have also failed, you will start ketogenic diet in the patient, which will be given for 3 months. This will comprise high fat, low carbohydrate and restricted protein diet. In resource limited settings, you can consider a modified Atkins diet. And what is the role of epilepsy surgery? In severe West syndrome associated with surgically correctable lesions like cortical dysplasia and structural anomalies present in neurocutaneous syndromes like tuberous sclerosis. So this is the management, the details of West syndrome that you need to know. Moving further, the next syndrome is Lennox-Gastaut syndrome, described by 2 different physicians, Lennox and Gastaut, their surnames. It's a severe refractory progressive epileptic encephalopathy, and remember, no child is born with Lennox-Gastaut syndrome. Lennox-Gastaut syndrome always occurs after the brain has been damaged, right? Lennox-Gastaut syndrome is a syndrome. It is not a specific disease. It is the end result of various types of insults, various types of epilepsies, eventually resulting in the same entity. So you will not find any specific gene being mentioned for Lennox-Gastaut syndrome. There are specific genes for various abnormalities, but for Lennox-Gastaut syndrome is the end result of epileptic problems. So Lennox-Gastaut syndrome, age of onset is between 2 to 10 years, and almost 60% are found to have an underlying cause like tuberous sclerosis, brain injuries which can be prenatal or postnatal. In certain other individuals, no cause can be found. About 20% patients evolve from preceding West syndrome. So if 20% means 1 in 5 children will have previous Pele West syndrome, it was there, now it has turned into Lennox-Gastaut syndrome. Most children are neurologically abnormal before the seizures begin. So they already have a neurological problem, right? What is Lennox-Gastaut syndrome? A classic triad of 3 things. First, there is developmental delay. Second, there are multiple refractory seizures. Atypical absence, myoclonic, atonic, also called as astatic seizures, and tonic seizures are the frequent ones. And all of them are refractory to conventional therapy. And third will be EEG abnormalities. The typical EEG abnormalities include 1 to 2 Hz spike and slow wave, polyspike bursts in sleep, and a slow background in wakefulness state. Please remember that normal EEG has findings like sleep spindle, K complexes, and vertex waves in sleep, but these will be absent in patients of Lennox-Gastaut syndrome. It is mentioned in financial. Now, along with EEG, obviously, MRI brain will be indicated in most patients to find what is the reason why these patients are having this syndrome. And treatment-wise, management is difficult, but first-line drug is usually valproate. Seizures are refractory, so you will require multiple AEDs like topiramate, lamotrigine, felbamate, and clonazepam. Felbamate is a very toxic agent, and so felbamate is usually added as a last resort. Clonazepam produces sedation, but clonazepam is useful. It is rapidly acting, and sometimes for bridge therapy, before you are changing a drug, clonazepam can be used. So if somebody asks you which drug AED used for bridge therapy means you know that once you give an anti-epileptic drug, till its therapeutic levels are attained in the blood, it is not going to be effective, and a lot of AEDs will require a gradual escalation in the doses. So what will happen is a particular drug is not effective and you are going to start a new drug, or you are going to taper a new drug and start a new drug, but there will be a gap in between in which therapeutic level of no drug will be there, so there may be status epilepticus in that. So for bridge therapy, till the new drug takes its effect, you will add clonazepam in these patients. So clonazepam and sometimes clobazam, benzodiazepines are useful as bridge therapy in severe refractory epilepsies like Lennox-Gastaut syndrome. Please remember this point. This is the meaning of bridge therapy. Now, rufinamide is also effective in many patients. If they ask you what is the new drug available for Lennox-Gastaut syndrome, it's a JIPMER PG entrance exam question, but still from entrance point of view, it's a one-liner that rufinamide is the new drug which is effective in some of these patients. Other modalities which can be tried, they include ketogenic diets, cannabinoids, corticosteroids and IVIG, and vagal nerve stimulation and corpus callosotomy have been used for refractory drop attacks in these patients. Drop attacks can happen, tonic seizures can cause frequent falls. The seizures in them can occur in both in sleep and wakeful state. If they occur in wakeful state, suddenly drop attack will happen, they may get injuries. For these drop attacks, vagal nerve stimulation and corpus callosotomy have been found to be effective, and as a last resort, surgical correction of surgically correctable lesion can be performed in these patients. Then there is a concept called as epileptic encephalopathic evaluation. What this concept basically says is that in about 20% patients of Lennox-Gastaut syndrome, there is a definite sequence. There is a definite sequence of development of epilepsies. So what will happen is that in the first 2 months of life, they will develop Ohtahara syndrome. Then between 2 to 12 months, they will develop West syndrome. And by the time they reach West syndrome will usually persist for up to 2 years of age. And beyond 2 years, some of these patients will develop Lennox-Gastaut syndrome. This is called as epileptic encephalopathy evolution. All of them are severe epilepsies. All of them show encephalopathy, and about 15 to 20% LGS patients, if you look at the past history, they evolve like this. This is the natural history. Not in all patients, but in subset of these patients. This is the concept of evolution of epileptic encephalopathy. Now, there is a differential diagnosis of Lennox-Gastaut syndrome called as DOOS syndrome. DOOS syndrome is also called as myoclonic astatic epilepsy. So there will be myoclonus as well as astatic, means atonic seizure, drop attack similar to LGS, but they will be milder in nature. And there will be no tonic seizures. This is the important thing. No polyspike bursts in the sleep. So they will have a better prognosis than LGS. Similar drugs can be used. Then there is a thing called as nodding syndrome. Nodding syndrome is an endemic disease particularly found in parts of Africa like Uganda as well as Sudan. Nodding syndrome is an acquired brain problem. Potential MCQ, it occurs as an autoimmune response to Onchocerca volvulus. The parasitic worm Onchocerca volvulus leads to a brain problem called as nodding syndrome. What is nodding syndrome? There will be brief loss of tone of the neck region. So there will be head drop in these patients. So atonic seizures causing head nodding. So intermittently, once the seizures begins, there will be intermittent loss of head tone, the neck tone getting lost, and so the child will start doing like this. Tone goes away, then goes away, comes back, goes away, then again comes back, goes away, then again comes back. So because the child is doing like this, that is called as nodding syndrome. And tonic and clonic seizures can also occur along with head nodding, and other features like encephalopathy, growth retardation, and cognitive dysfunction have also been seen. Treatment is supportive. Not a very good response is seen to most therapies. Valproate and phenobarbital have been tried in these patients with, of course, limited success. Then we have a term called as progressive myoclonic epilepsies. They will have progressive dementia and myoclonus with age. There are two autosomal recessive variants. Both of them are autosomal recessive that you need to remember, that can be asked in your exams. The first variant is called as Unverich-Lundborg disease. Unverich-Lundborg disease is caused by cystatin B or CSTB mutation. It is also called as type 1 progressive myoclonic epilepsy. It starts in adolescence, usually starts in adolescence, although the range given in Fenichal is between 6 to 13 years, but majority of them will present somewhere around 10, 12, 11, 12, 13 years, and it is a slowly progressive disease. It is characterized by stimulus-sensitive myoclonus, and tonic-clonic seizures can also develop. It is a myoclonic epilepsy, but as opposed to type 2, as we shall see in type 2, there will be inclusions present in the biopsy of muscles. Here, no inclusions will be seen, and photosensitive EEG abnormalities will be there. Treatment will include valproate, zonisamide, and levetiracetam. The second variety is type 2, that is Lafora body disease. Lafora body disease is due to mutations in either Laforin, which is EPM2A gene, or Malin, which is EPM2B, now renamed as NHLRC1 gene mutation. Laforin gene mutation, that is EPM2A gene mutations, are responsible in about 80% cases. Laforin is a type of tyrosine kinase inhibitor which is involved in glycogen metabolism, and that is why in these patients you will find that extra CNS problems like inclusions in muscles and sweat glands can also be seen. It begins in adolescence or early childhood and are rapidly progressive. There will be tonic, clonic, and myoclonic seizures. Hallucinations from occipital seizures can also develop. It is not mentioned in Nelson but mentioned in other standard textbooks. Photosensitivities in EEG is present. Ataxia and spasticity can also develop. When you do biopsy, PAS positive Lafora inclusions will be seen on muscles. You can also do skin biopsy where you will find these inclusions to be present in acrine sweat glands. And they are rapidly fatal within second or third decade of life. The treatment is similar to type 1. Potential MCQ. Fenichal says that AMPA receptor blocking drugs like perampanel, also called Fycompa, have been found useful in a minority of these patients. So it is a very specific drug, not useful in other varieties of seizures, pediatric seizures, but it has been found useful in type 2 progressive myoclonic epilepsy, that is Lafora body disease. Now, it is not only that these two autosomal recessive conditions, but there are other causes of progressive myoclonic epilepsies also. From entrance point of view, you may get questions like, which among the following is not a cause of progressive myoclonic epilepsy or not associated with progressive myoclonic epilepsy? So it's a very fancy list. Don't worry, you're not supposed to remember the details of each of these. You can do that once you take up pediatric neurology DM, but at least the names are important. So what are the names? The mitochondrial disorder, MERRF, myoclonic epilepsy with red tract fibers, sialidosis type 1, neuronal ceroid lipofuscinosis, particularly the juvenile variant, type 3 neuronopathic Gaucher's disease, Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is not mentioned in Nelson, but it is mentioned in Fenichal as well as multiple review articles. Dentatorubral pallidoluysian atrophy, action myoclonus renal failure syndrome, progressive myoclonic epilepsy, ataxia syndrome, and not C progressive myoclonic epilepsy. So these are the conditions in which, similar to autosomal recessive forms, you can find, similar to type 1 and type 2, you can find sometimes progressive myoclonic epilepsies. And then we come to the last topic of this lengthy video discussion, that is Landau-Kleffner syndrome. Again, described by two people with their surnames being Landau and Kleffner. They can have autoimmune or genetic basis, and if it is a genetic basis, they have mutations in GRIN2A. Age of onset is 3 to 6 years as per the Nelson 21st edition table. Why I mentioned reference here, different textbooks different review articles. Adult neurology textbooks also give a different range. For us, we need to follow what is given in Nelson. If you read the text of Nelson, they have not talked about the age of onset, but there is a table in the beginning of the chapter of the beginning of the unit of pediatric neurology, where they have talked about the age of onset of various conditions. There they mention it as 3 to 6 years. There is a progressive loss of language skills once the disease begins. So up to 3.5 years, the child will be fine, and then there will be regression of language milestones, along with verbal auditory agnosia, that is inability to comprehend speech. At least 70% will develop seizures. There will be multiple types, including focal, tonic-clonic, atypical absence, and myoclonic seizures, etc. The focal ones can be with comprehension and with loss of comprehension. EEG will show bitemporal problems. Remember, bitemporal anomalies in the form of high amplitude spike and wave discharges, especially during NREM sleep. That is why a sleeping EEG is indicated in Landau-Kleffner syndrome. Frontal areas may sometimes show a normal finding. EEG tends to become normal later once the disease, some degree of remission comes somewhere in the adolescent period. You will find that EEG tends to become normal. And some patients may show ESES, very important. What is ESES? Electrical status epilepticus in sleep. There is no clinical status epilepticus, but in sleep, electrical activity pertaining to status epilepticus is often present. So, what is the therapy? For seizures, you need to give valproate and clopazam. They are the first line agents. For aphasia, that is the speech problems, verbal agnosia, nocturnal diazepam will be needed, which is the drug of choice, followed by oral steroids like prednisolone. The problem with prednisolone is if you give it, you need to taper it, and when you taper it again, these patients tend to develop a relapse of the problem. And IVIG may be considered in such patients where you, on tapering the steroids, the aphasia is returning. And what is the differential diagnosis of LKS? There is an entity called as continuous spike waves in slow wave sleep. It is a condition in which ESES, electrical status epilepticus in sleep, it can occur in more than 85% of the slow wave sleep. Discharges are usually frontal or generalized. In Landau-Kleffner, they were in the bitemporal region. Here they are frontal or generalized. Secondly, they also have developmental delay, this entity CSWS, but it is a global developmental delay, not verbal language related alone. And therapy is similar to that of LKS. Prognosis is usually guarded. Before I finish off, there was a recent MCQ asked in one of the entrance exams, not NEET SS, but another entrance exam, couple of years back, where they had asked about the genetic basis. It was a statement-based question related to the genetic basis of West syndrome and its epidemiology, right? Now, there are few one-liners that I've compiled from multiple areas, including some Indian review articles that you need to know along with Nelson. So, first thing that you need to know is that in India, in Western world, usually West syndrome occurs, the cause of symptomatic, that is secondary West syndrome, is genetic, followed by perinatal asphyxia. In case of Indian setting, the cause of symptomatic West syndrome is most commonly perinatal asphyxia, followed by brain injury due to hypoglycemia, followed by genetics reasons including syndromes. So this is one thing which is different and you need to remember from exam point of view. And second exam point of view is male with West syndrome, male baby with West syndrome, what is the common gene mutation which is implicated? The common gene mutation which is implicated is ARX gene mutation. These children will have problems like West syndrome. They will have problems related to ambiguous genitalia, and they will also have problems related to cortical migration defects, right? So these are two additional things I wanted to discuss in the end as a standalone extra edge point which you can add to your notes. So it was a lengthy video. The time I've spent on a topic, it's related to its importance from your entrance exam, and I've not tried to go into those rarest of rare things, although I have covered some rare topics as well. But this video is going to be very important, very productive for your super specialty exam, be it INISS or NEET SS. Revise it at least 2 to 3 times, and anything more you can add, great. If not, at least whatever I have discussed so far, it should all be in your grasp before you sit for your exam. Hope it helps. Thank you very much.